This conference will now be recorded.
Hello? Hello?
Hello.
Hello.
My voice clear?
Yeah.
Yes, your voice is clear.
Yes. Yes.
Doctor, your voice is feeble actually. Dr. Ali,
My
your
voice
voice is very feeble. Low pitch. It's very low pitch.
is very low.
Yes, doctor, it is still low, very low.
Hello? Hello?
Hello. Yes, doctor.
Is my voice clear?
Yes, doctor. It's clear.
Yeah, now clear.
Okay.
Yeah.
Okay. So now we can start, inshallah. Hi, all my colleagues. Today, inshallah, we are going to talk about three of the module of our curriculum. Um Today, our session about the module of labor and delivery and postnatal. There are many cases or a lot of cases which can appear in these three modules. For example, you may have a patient who came to discuss the place of delivery, and this patient has some concern, like she may have a fibroid in her womb and she wanted to have a home delivery, or she may have previous cesarean section and she also wanted to have a home delivery. She may be have twin pregnancy. All of this can came as a patient coming to discuss her place of delivery, and there is concern about her pregnancy. Also, you may have in this module a patient who have a complication in her previous pregnancy or in her previous delivery, like patient who have third or fourth degree perineal tear, and she came today to discuss her mode of delivery. Patient who have shoulder dystocia in the previous delivery, and also came to discuss her mode of delivery. You may have also a structured discussion task in these modules for a lot of topic in our curriculum, like a patient with severe preeclampsia. You may have a structured discussion task about this. Maternal collapse. You also may have a patient in the postnatal period who have a headache, or patient who complain of symptoms suggestive of DVT. All of this can came in the patient who came in the postnatal period. Also, you may have a structured discussion task about the cesarean section. This also module you may have, it may come in the module of teaching, at the module of teaching, like teaching the discharge letter, teaching your junior the third stage of labor, teaching the partogram, teaching mechanism of labor. All of this can came in the module of labor and delivery and can be considered also as a teaching. One of the most important scenario or one of the most important tasks which you may face in the labor and delivery module is the labor ward prioritization, and this task they like it very much. It appear in our exam. Also, you may have in this module breaking bad news a station to how to break bad news, like if the patient has IOPD and you have to tell her about the result of the scan like this. Also difficult station like angry husband and his baby is IOPD. All of this can appear in the labor and delivery, and a lot of cases from our curriculum you may find to be covered in the labor and delivery and the postnatal module. So you have to study all of these cases and to focus on the most important one. Okay, so let's start by the first case. So, Doctora Nima.
Yes, doctor.
Okay, welcome. The first time to share with us. Am I right?
Yes, yes, sir.
Okay, you are welcome.
Thank you, sir. Same.
Okay, so Dr. Purnima will do this task. This is a structure discussion task. I will adjust for you 2 minutes.
Yeah, sir.
Start, please.
Okay, sir. Okay.
Okay, 2 minutes finished. 2 minutes
Yeah.
finished. Okay. You
Okay.
can now enter the cubicle and introduce yourself to the examiner.
Hi. Hello. Good morning, sir. I'm Purnima, one of the exam going student. I'll be giving the exam.
Okay. Doctor, you have read the instruction about our case today. So what is the important information you wanted to know more about this patient?
I want to know, is this our first pregnancy? And I also want to know since when she had this abdominal pain, tightness and vaginal spotting. And since she is an Rh negative pregnancy, I would like to also know whether she has any issues of blood transfusion, and also I would like to know about her fetal movements. How is it? Mm,
Yeah.
And so, is it a vaginal spotting, or is it a fresh bleeding? And also, I would like to know any allergies to any medications, and did she undergo any surgeries in the
There's no
past?
voice, no sound.
And any surgeries in the past? And also, I would like to know any smoking history, and also I would like to know about alcohol, any recreational drugs she has been taking. And I also would like to know her about the previous scans, dating scans, and also her structure detail scan, any recent scan to know the localization of the placenta.
Okay.
Okay. And if need, I also would like to know any findings. It will be helpful to uh, uh, come to the diagnosis.
Excuse me, Dr. Burnima. Can all mute yourself, please? All my colleague, please,
Yeah, yeah, sir, yes, sir.
not to disturb us. All my colleague has to mute themselves, please, except Dr. Burnima. Okay.
Okay, sir. So
Okay.
these are the important points I would like to gather, I mean, in this patient.
Okay. Okay. This is the history, Dr. Burnima.
Okay.
Can you
Okay,
have
abdominal
a
pain
read for
on.
this?
Yeah. Yes,
Yes.
sir. Abdominal pain on and off since 3 hours with vaginal spotting. No vaginal water loss. Her baby movement is good. She's 27 years and has a second pregnancy. Previous vaginal delivery uncomplicated since 3 years. Spontaneous at term. Uh, she's 31 weeks, uneventful pregnancy. No medical or surgical history. No allergies. Non-smoker.
Okay.
Okay.
What are the examination you wanted to do for this patient?
So I would like to see any abdominal tenderness, or there are any contractions or only tightness. And I would also like to see the check the fetal heart rate. And down below, coming to the internal examination, I would like to do perspectival examination if there is any leak, or to rule out leak, and also to see I mean, what is the color of discharge, whether it is just a spotting or a fresh bleeding, um, or is this a altered blood. I want to confirm the findings.
Okay.
I would also like to check her blood pressure and pulse.
Okay.
Okay,
This is okay.
okay. Vital stable, abdomen soft, lax with infrequent contractions every 10 minutes. Uh, FL equal to date. Okay,
Fundal level
equal to
equal to yes.
what's it? FL?
Fetal heart rate
Oh,
by handheld Doppler.
fetal heart rate by handheld Doppler is 140 beats per minute. Local examination cervix is 2 to 3 centimeters soft. Central 1 to 2 centimeter long. No vaginal loss.
Okay.
Okay.
So what is the important investigation you wanted to do for this patient?
Okay. I would like to do vaginal swab. Then all vaginal swab to rule out any infections, and also uh, I would like to uh, uh, send send vaginal swab for the fetal fibronectin, if available. Mm.
Hmm?
So she's 31 weeks. I would like to send her, send the full blood count and also for any raised total counts to look off to, and also I would like to.
Okay, Dr. Bonima. So now,
Yes, sir.
after the investigation you did for this patient, you diagnosed this patient in preterm labor.
Yes,
Now
sir.
you diagnose this patient in preterm labor. So how you will manage this patient?
So she's 31 weeks, gravity 2, and she's in labor, early phase of labor. So I would like to give her first. She's already in labor, due to the active labor. So I would like to give her what is it? I would like to relax the uterus. I would like to give her nifedipine tablet, and also I would like to give the for babies lung maturity. I would like to give betamethasone, which will be for 12 milligram, and if anticipating the delivery within 12 hours, it may be repeated again after 12 hours, and anticipating the anticipating the labor within 24 hours. I would like to consider magnesium sulfate for this. After giving the uh, treatment, since our hospital has been closed. Our hospital NICU has been closed due to shortage of the staff. I would discuss with the partner, with the patient and the partner about the shortage, and so I'll be sorry for them, and I'll arrange for an in utero transfer of the mother and the baby to a higher center where there is a delivery suite and also as well as a NICU facility.
Okay, so how you will arrange the in utero transfer for this patient?
So I'll make sure that one of the specialist midwife and also a specialist midwife and a junior, ST2 or to take care while transferring. And also I'll inform the hospital where she is being shifted about the arrival of this patient, of the mother and the baby, and also I'll make sure that the NICU facilities where the patient is going to be shifted is available, and I'll inform them the what treatment has been given and what is the findings and also I'll make sure that the consultant and the pediatrician is available over that hospital.
Okay. Anything else you wanted to add?
So since this patient is an Rh negative pregnancy, I'll make sure that the blood has been arranged and also is being arranged in case if it is required. So I'll tell
Okay.
about the Rh negative pregnancy also.
Okay. Okay. This patient in her future pregnancy, what is the precaution you will do for this patient?
What, sir? I didn't get.
Huh?
So I didn't get the question, sir.
Okay, thank you. Time is finished.
Okay.
Now we will come to the feedback.
Okay.
Thank you, Dr. Abdulrima, about your sharing today. It
Thank
is
you,
very
sir.
good for
Thank
the
you.
first time. Yes, you
Okay.
are welcome at any time. You did well
Okay.
in
Thank you
this
very much, sir.
case for the first time, and inshallah, by practice and by doing more and more patients, you will be more better, inshallah. You cover most of the point, and you time to you manage to finish with time. Um, you did well, I think, except for the information gathering or the first question, the history taking and the information gathering. You didn't do well in analysis of the the present, the history of the present illness. First, this patient came with abdominal tightness and vaginal spotting, and she is in 31 weeks. So you have first to put a differential in your mind. What can be in this patient? What the diagnosis can be in this patient? All the section discussion task, all you have to put differential in your mind, and this is to show from the first moment to the examiner that you are systematic in thinking and systematic in managing the case. So put differential in your mind, and you can tell the examiner this differential because to show the examiner how you are, how you think about the case. So this patient may have preterm labor, or she may have antepartum hemorrhage. So I will put this differential, and according to this differential, my question will be, so I wanted to know more about this patient from her history and from her notes. So I will gain more information from the patient history and from her notes. Okay, so from the start, you show the examiner that you need to access to the patient note to know more about her, whether the scan, the scan before, like the ultrasound scan she did before, animal scan, early scan, and the result of her investigation, like the anti-RBCs antibody, the kidney function, the liver function. You have to show the examiner that you wanted to access to the patient note to know more about her. So gaining information or gathering information not only from the history, it includes also the patient note and the examination. And as I told in the first session I did, information gathering usually include examination and investigation also. So I wanted to know more about the patient from her history and from her notes. I will introduce myself to the patient and my role and confirm the identity. Don't forget to tell this for the examiner. Okay. Also, it will be as a patient safety that you show the examiner this is the systematic way you will do for any case. Either it will be simulated patient task or structured discussion task. So first, I will introduce myself to the patient, my role, and confirm the identity of the patient. Then I will ask about her complaint in detail. What her complaint? She has bleeding and she has pain. So I will ask about this pain in detail, and you have to justify for each thing you tell to the examiner. I will ask her about how regular this pain, how often this pain, okay, to know whether this is a frequent labor pain or only at one time and finished, and this is regular pain, this is true labor pain or no, this continuous pain or on and off. So if it was continuous pain, she may be antepartum hemorrhage, but if this pain on and off pain, this may be labor pain. I will ask about any blood loss, how much is the blood loss if there is blood loss. I will ask about the water loss to exclude preterm pre-labor rupture of the rupture membrane. I will ask about her baby movement. Also, it is very important to ask her about how she is appreciate her baby movement to check the well-being of her baby. Ask about this pain, whether she has this pain before or no, any history of trauma. She may be domestic violence and she has trauma at home. So this is how to analyze the complaint. First, you have to catch the complaint and ask about all detail of her complaint. Then I will go systematic as we used to do, obstetric history, gynecological history, medical history, not to forget anything. Regarding to the obstetric history of this patient, I will ask about her current and her past pregnancy. Her current pregnancy, I will ask how far she is in the pregnancy, how many weeks to confirm, and about the result of any scan. Any doctor tell her about any concern about the scan, like if she has twin pregnancy, if she has polyhydramnios. This is maybe a risk factor or predisposing factor to the preterm labor. Also about and ask her about any concern about the result of her tests she did in this pregnancy. Ask her about the NTD. She received NTD or no, because she is now 31 weeks. In the past pregnancy, it's very important to ask about her previous obstetric history, whether she has preterm labor or no, because there is a risk of recurrence. If she has preterm labor before, she has PPROM before, if she has second trimester loss, it's very important. All of this you have to ask in the obstetric history. Regarding to the gynecological history, according to the patient age, you will ask about the cervical smear. This patient is more than 25 years, so you will ask about the cervical smear history. Any medical history, any surgical history, like any surgery of the womb or the neck of the womb, because if this patient has did a surgery in the neck of the womb, like leads or an operation like that, it may be exposed also to the preterm labor. The allergies also we have to use. We used it to ask about the allergies as a patient safety. Smoking, because smoking is a risk factor for the preterm labor, so I will ask this patient smoker or no. Social support at home to exclude domestic violence, and psychological history. It is very important in the obstetric patient to explore about her psychological illness. Then I wanted to review the patient note to know the result of her scan, whether any polyhydramnios, any multiple pregnancy, the position of the placenta. It's very important because this patient has bleeding. She may be placenta previa or something like that. So to see the position of the placenta and the presentation of the baby is also important because this may decide her mode of delivery. Also, I will review the result of the blood test to see whether she has NTD antibody or no. This patient sensitized or not sensitized. Because if she is sensitized, I will not give her NTD. This is regarding to the information I wanted to know about the patient. Okay, so the examiner now, he will hold another paper and give it for you. He will give you this paper and they say, doctor, this is the history of this patient. Okay, from the history, as you see, this patient has abdominal pain on and off pain since 3 hours, and she has vaginal spotting, no vaginal loss. Her baby movement is good. She is 27 years old, and she is gravida 2 para 1, previous vaginal delivery uncomplicated since 3 years, spontaneous at term. She is now 31 weeks, uneventual pregnancy, no medical history, no surgical history, no allergies, and non-smoking. The examiner will come to the, or will go to the next question and ask you about the examination. And please don't jump to any question unless the examiner asks you about that. So now you will ask, the examiner will ask you about the examination. What is the important examination you wanted to do for this patient? Systematic also, vitals, abdominal, and local. You will say, I want to examine this patient in the presence of chaperone after taking her consent. Don't forget this point. Don't forget the chaperone and the patient consent will be considered patient safety also, even in the structure discussion task. So I will examine this patient for the pulse, blood pressure to check that she is hemodynamically stable, and I will check for the temperature to exclude for any infection like urinary tract infection may be the cause of this preterm labor. I will examine her abdomen for any labor pain, any tenderness to exclude antepartum hemorrhage. I will check her fundal level to assess the growth of the baby. Okay, fetal heart rate to check the well-being of the baby. So when you tell anything from this examination, you have to justify. It is not accepted to tell I will examine the patient for the pulse, blood pressure, and stop. No. Or you tell the examiner I will take the vitals of the patient. No, it's not accepted to tell that. You have to say I will take the pulse, blood pressure, and this is for what? The temperature, and this is for what? So you have to justify everything you will do and everything you will request. I will do local examination by the speculum, and this to see any cervical dilatation, any bleeding, any vaginal discharge, and if the placenta is high, I can do digital examination, no problem. Okay, the examiner will hand another paper for you. He will give you another paper after you will ask about the examination. He will give you this paper which include the result of the examination. Okay, doctor, now the patient is vitally stable. And by abdominal examination, the abdomen was soft, lax, with infrequent contraction every 10 minutes. The fundal level is equal to 8, and the fetal heart rate by handheld Doppler is 140 beats per minute. A local examination, the cervix is 2 to 3 cm soft central, and 1 to 2 cm long with no vaginal loss. Okay, from this examination, you will suspect that this patient has preterm labor because the cervix is 2 to 3 cm soft and central. This is some cervical channel. So this is suspected preterm labor. What you will do, the examiner will ask you now, what is the investigation you wanted to do for this patient? Now you wanted to diagnose preterm labor according to the NICE guideline for the preterm labor. So what you will do for this patient, first you will say that I wanted to check for any infection. This is by vaginal swab or by the urine analysis to test for any urine infection and any vaginal infection may be responsible for this preterm labor. Also, ultrasound scan, abdominal ultrasound scan to check for any polyhydramnios, any multiple pregnancy. If this not confirmed before, gestational age presentation, because this will justify or will decide the mode of delivery. And if this patient is more than 30 weeks, I will do the diagnostic test for the preterm labor. All of you know that the preterm labor, if it's less than 30 weeks, you will you will confer or you will diagnose the preterm labor only by the clinical examination. No need for the investigation. But if it's more than 30 weeks, you will diagnose the preterm labor by investigation, diagnostic test. You have to test and diagnose the preterm labor either by the vaginal ultrasound or by fetal fibronectin. First, a vaginal ultrasound to measure the cervical length. If it is less than 15 millimeter, I will diagnose preterm labor. If the ultrasound is not available or not accepted by the patient, so I will do fetal fibronectin test. If the fetal fibronectin more than 15 nanogram per milliliter, I will diagnose preterm labor. And remember, he can ask you about the fetal fibronectin, about the sensitivity and specificity. This fetal fibronectin, if it's negative, if it's negative, 1 in 100 will have preterm labor in 2 weeks. So it has high negative predictive value. And if it's positive, 1 in 5 will have preterm labor in 10 days. So this is the investigation you have to ask for this patient. The most important investigation to diagnose the preterm labor are the vaginal ultrasound and the fetal fibronectin. And also we can check for any infection which may be exposed for this patient by the vaginal swab and by urine analysis. And abdominal ultrasound for the exclude also the risk factor like multiple pregnancy, polyhydramnios, check the presentation and the gestational age of the patient. Examiner will tell you that you diagnose that this patient is in preterm labor. So how you will manage this patient? First, you have to tell this patient need admission. Okay, this patient, this is a safety point. This patient need admission. She is in preterm labor. What she will do in this admission or what she will have in this admission? 4 things. Don't forget any one of them. 4 things in the preterm labor. Corticosteroid, lenticulitic, magnesium sulfate, and antibiotic. Please, you have to remember by your heart these 4 things in the preterm labor. Don't forget any one of them. Corticosteroid, 2 injection 24 hours apart for the lung maturation. Ticolytic, and you have to justify when you will use this ticolytic and for what. This to let the patient get benefit from the corticosteroid, or if she will have a neutral transfer like our patient today. Okay, we want, as according to the NICE guideline, we don't give the ticolytic if the patient in active labor or if the membrane is ruptured. So I will give if the patient not in active labor and the membrane is intact. Magnesium sulfate for the neuroprotection if she will deliver in 24 hours. This is the opposite to the ticolytic. If the patient in active labor, I will not give her ticolytic and I will give her magnesium sulfate, and vice versa. If the patient is in active labor, I will not give her that. I will give her the magnesium sulfate. If she is not in active labor, I will give her the ticolytic and I will not give her the magnesium sulfate. Okay, the magnesium sulfate if the patient will deliver in 24 hours. Antibiotic against the group beta strep if the patient in active labor. According to the Green Top guideline, antibiotic against group beta strep, it will be given for all patients who have preterm labor. Either she was positive for the GBS or she wasn't tested for the GBS. So I will give her these 4 types of the drug. Don't forget any one of them. And as the patient is RHD negative and she has vaginal spotting and the pain, okay, so this is 2 sensitizing agent. I will give her anti-D 500 international unit and the test for the fetal-maternal hemorrhage to check for any other doses. Okay, but this patient is in a problem because your hospital closed the NICU. So before that, you have to call the neonatology doctor to come to talk with the patient about the outlook of her baby and about the availability of the cot because our NICU is closed. In this time, the examiner will ask you about the in utero transfer. He will say, so now how you will arrange this in utero transfer for this patient. In utero transfer will be done if the condition of the patient permit. I will discuss this with the consultant. I will discuss this with the consultant neonatologist. Don't forget the patient. Don't forget the patient and her partner. I will discuss this with the patient and her partner and take her consent. You have to take consent from the patient about the in utero transfer, because if the patient refuses in utero transfer, you can't do that. Communicate with the consultant obstetrician and the neonatologist in the recipient hospital. So in the hospital in which you will refer the patient, you have to talk with the obstetrician and the neonatologist is there and the labor ward assistant. When you will talk to any of your colleagues, you have to talk by the SPAR tour analysis. SPAR tour analysis is abbreviation of four words. S for situation, P for background, A for assessment, and R for recommendation. So when you will talk to any of your colleagues, whether it was your consultant or was the consultant obstetrician or even the labor ward sister, you have to talk with the SPAR tool analysis. Situation, you will give her the situation now. I have patient with preterm labor. The background will give her some information about the patient history, like she is gravid at 2 around 31 weeks with no medical or surgical history, came with tightness and vaginal bleeding. What was your assessment? What was your general and abdominal and local examination? You have to tell by this patient blood pressure like that, pulse like that, abdominal examination and local examination like that. And what are your recommendations? This patient need to be admitted for 1, 2, 3, 4. So this is how to handle a patient for to any of your colleagues by the SPAR tool. And the patient, as you said, Dr. Aburnima, this patient need to be transferred by medical staff who are oriented about her case and to take photocopy of her note, not the original one. When you will transfer this patient to another hospital, you will take a photocopy of her note and the original one will be kept in the hospital. Okay, this patient refused in utero transfer. So what you will do? If the patient refuses in utero transfer, you will explore why. Any patient refuse anything, you have to ask why. This is very important word. You have to ask why you don't want. The patient don't want to have a utero transfer, so you have to ask why. The patient don't want to have a hospital delivery, ask why. The patient don't want to have cesarean section, ask why. So why this patient doesn't want to have a utero transfer? And this is not only the question, and this is not only the thing you did. Okay, why? Because doctor, I don't want to go there in other hospital. So you will document only. No. Before documentation, you will explain the risk. So any patient refuse any treatment against the medical advice, you have to ask why and to explore the risk. Not only document. You document it to protect yourself. It's okay. but you have to explain the risk for the patient. The patient doesn't want to have a hospital delivery and wanted to have home birth. So you have to explain the risks of the home birth in her situation. So you have to explain the risk for this patient, what can be done, what can be happen for her baby, and after that you will document this clearly in her notes. So you will ask why, explain the risk, and after that document. The patient still insists after you explaining for her the risk, so you will go to document your notes. Explain for the hair that the safety of the baby in utero transfer will be better than ex utero transfer. Also, after that, if the patient still insists, you can arrange a discussion with the neonatologist. The neonatologist may make her change her mind. Respect her autonomy. If the patient doesn't want to have a neuter transfer, you have to respect, but you will have till there you have to tell her that after delivery of the baby, we will do the best interest for the baby. The baby inside the uterus or intrauterine has no right at all. So the mother can take the decision on behalf of the baby. After the delivery, no, we will do according to the interest of the baby. Okay, so if the interest of the baby necessitate from us the ex utero transfer, we will arrange this transfer to the another hospital. This regarding to this task, it's very important task, very important task, appear many times in part 3 examination. So any question?
Sir, just I wanted to make you sure that GPS, whether it is there or not there, any preterm cases we have to give antibiotics?
Again, can you come again, Dr. Deputy?
Sir, I have one query that any preterm cases, confirmed preterm cases or history like this, and whether GBS status is declared or not declared, whether we know a GBS is positive or negative, irrespective of that, we have to give her antibiotics?
Yes. Any patient in preterm labor, whether you know her GBS status or you don't know, whether she is GBS positive or she doesn't screen for GBS, so you have to give her antibiotic against group beta strep.
Okay. Thank you, sir.
Okay, welcome.
Okay, Dr. Ali.
Dr. Hassan, اتفضل.
Yes, okay. Regarding the antibiotic, I think that if the patient is opt for CS and she comes with no rupture of membrane and preterm, I think in such condition we don't give antibiotic. It's according to the presentation. If this breach and with no rupture membrane and the preterm, I don't think she will need antibiotics. What's your opinion?
According to the green top of group beta strep 2016, it is clearly stated there and clearly written there. If the patient in preterm labor, whether you know her GBS status or you don't know, give her an antibiotic against group beta strep. I can share this
I think
guideline.
this regarding vaginal delivery. I think this I agree with you.
Yes, sure. This is if vaginal delivery and not the cesarean section. This is what I mean. Yes.
Yes. Oh, I say in case of cesarean section, she doesn't need.
Yes, in case of cesarean section and the membrane is intact, no need to give her antibiotic. Yes.
One question: in such a scenario, patient came early in preterm labor and she is blah blah blah, and there is no available vacant bed in the nursery. When we start the measures for referral of this patient with the recipient hospital, the hospital will start with her initial measures like that, giving antibiotics, giving tocolytic steroid, or we wait until she go to the recipient hospital and she will receive their all the measures.
Yes, I understand your question. You can't if the examiner asks you a question like that, okay, till the arrangement will done, you don't know when this arrangement will be finished. This, as you know, it may take time, 3 hours, 4 hours, maybe 10 hours till they find a vacant cot. So you have to start the treatment immediately. Give her the corticosteroid now. You can start the therapeutic now. As you know, the first drug, the first choice is nifedipine. So you can give the nifedipine for the patient to get benefit from the corticosteroid like this. And you can start also, if the patient is in active labor, you give her the antibiotic. So you don't know when this arrangement for the transfer will be finished. So you have to benefit from your time.
Okay, thank you very much.
Thank you, Dr. Hussein.
Dr. Ali, I have one question.
I wanted to clarify one point for all of you. In the examination, it is nothing true and nothing false at all. I mean that you have to justify your opinion. As I tell to Dr. Hussein, you have to justify. If the examiner asks you any question, you have to tell, I will do that, and to justify why you wanted to do that. Okay.
Dr. Ali, can you share the first slide?
Again, Dr. Sharda, what do you say?
The history slide, the first slide. You talk about what are the points we need to.
I can't hear you, Dr. Sharda. Sorry, I am so sorry. I can't hear you.
Dr. Ali, I have one question.
Yes, Dr. Saima?
Do we need to give NTD irrespective of blood group of partner?
Yes, here you don't know the blood group of the partner. If you wanted to enter yourself in the dilemma and I wanted to ask about the blood group of the partner, okay, ask about the blood group of the partner, and but here the blood group of the partner didn't mention. So in this situation, you will say I will give her the patient NTD. If you wanted to tell the examiner, I wanted to ask about the blood group of the partner, and if the partner is RHD negative, I will not give her. It's okay.
Okay, thanks.
One
Hello,
quick
Dr.
question.
Ali. Dr. Ali,
Dr. Hussein,
I think regarding NTD given or not, we should stick to the rules. They give NTD according to the test of the baby. They don't guarantee who is the father of this baby. Even if the father is Rh negative, they stick to the rules. This is first point. Second point, as routine. They give either 1,500 international unit at 28 weeks, or they give 2 doses, 500 international NTD at 28 and 34 weeks. So it's given if it's given, no problem. This as a routine antenatal care. Do you agree with me?
Yes, this is a routine NTD prophylaxis for all patients. Yes. Thank you, Dr. Hussein.
Just one quick question, Dr. Ali, that in this case, it looks like the patient's placental localization was done and it was fundal or not previa. But if we are concerned that the placenta is covering the os and the patient has spotting, then we can do the transvaginal ultrasound and per speculum and avoid vaginal examination. Thank you.
If the ultrasound reveals that the patient has the placenta covering the os.
Yes.
So I will do speculum examination. Speculum examination will not change, will not affect or will not harm the patient from the speculum examination. But I will not do vaginal examination.
This is what I wanted to confirm with you, that even if it is a placenta previa, we can still do the per speculum examination and the transvaginal scan. Both can be done. So the only precaution will be that we will not do the vaginal examination. I just wanted a confirmation from you.
Yes, Dr. Anil. Yes, you are right.
Sir, one question. You
Please
are
share
telling
the
about
first slide.
Dr. Aburnima, okay. Dr.
yeah,
Aburnima.
sir, Yes, sir. You're telling like vaginal, I mean, ultrasound will be done after 30 weeks to diagnose preterm labor. So I was not able to hear at that time. Can you please explain me one more time?
Yes, according to the NICE guideline, they say that if the patient, we can diagnose preterm labor by the vaginal ultrasound or by the fetal fibronectin test. If the patient is coming more than 30 weeks, I will do this diagnostic test. But if the patient came before 30 weeks, like 28, 29, 29 plus 6 days, so now no need for this diagnostic test. I will start immediately the treatment of the preterm labor. So according to their care, if the patient came before 30 weeks, complaining of symptoms suspected of preterm labor, start immediately treatment of the preterm labor. But if the patient came more than 30 weeks, they have to do first the diagnostic test before starting the treatment. This is according to the NICE guideline of preterm labor.
Okay, sir. Thank you so much.
Okay, welcome, Dr. Nima.
Sir, last question. What about Maxelf, sir? Some more than 30 weeks, meaning we have to give or Maxelf?
Again, what about what?
Sir, in preterm cases, how to justify that Maxelf issue? Because sometimes it is saying that if it is not established labor, then no need. If it is established labor, then only we have to give. So all this is confusing points.
I didn't hear you well, Dr. Adipti. Please say again. Come again, please. Sorry, I'm so sorry.
Sir, my query is about Maxel. As per the guidelines, we supposed to give her Maxel, but again, one catchy sentence is there in the guideline in the case of established preterm labor. When you are
Yes, according to
expecting
magnesium
delivery within
sulfate.
24.
Yes, according to magnesium sulfate, it will be given if the patient in active labor or you suspected that the delivery will done in 24 hours. So either the patient will deliver by vaginal delivery or by cesarean section, any method of delivery, vaginal or cesarean section, and the patient in preterm, this baby is preterm, so you have to give the patient the magnesium sulfate within 24
Like
hours of the delivery.
person like this kind of patients where it is like a threatened preterm, it is not established preterm. In
Yes,
that case,
we give in
should we bring that point about myself to in exam?
yes, we give in the established labor, not in the threatened preterm labor. And in the
Yeah.
NICE, in the NICE guideline, there is no now threatened preterm labor. There is now suspected preterm labor, established preterm labor, and diagnosed preterm labor. No threatened preterm labor now in the NICE guideline. Suspected
Yeah, suspected.
and diagnosed. Yes.
Yeah.
So and
So, sir,
we
like
give
this
in the
kind of
established, not
scenes.
in the suspected. When the cervix become 4 cm, 4 cm or
Yeah.
more.
So, like in this case, sir, it is 2 to 3 centimeter dilatation is mentioned. So, we should
Yes,
tell this
we
point
said
in
we will
exam or
give.
no?
Yes, we will give the patient if the patient become in established labor. We will have to say like that.
Established. Like that we can. Okay, okay.
Yes.
Thank you, sir.
Okay. Welcome.
Dr. Ali, regarding the that notes, something you told, the original notes the patient takes with her, or the original notes will be in the primary hospital? I didn't get clear. I was not clear about that notes.
The notes of the patient.
Yeah, I mean that one. Yeah.
The notes of the patient may have a handheld notes, or according to the system of the hospital, it may be on the system electronic.
You told that original copy will be with whom? Original copy the patient will take to the referring hospital, or it will be in the primary hospital?
The patient will have a follow-up. In the UK, the patient will, if the patient is low risk patient, she has her follow-up in the midwifery unit. And if any concern happen about the patient, she will be referred to the hospital. The patient will take a paper, referral letter from the midwife about her notes to the obstetrician in the hospital, and she will have her hand-held notes.
Okay. Okay.
Okay. Okay. Who wanted to share the next question? Dr. Saima?
Sir, I want to present next case.
Okay. This is the case, Dr. Saima. We will do this case, Dr. Saima, but if you please, or my colleague, I will take a break 10 minutes to pray Maghrib.
Okay, okay, sir.
Okay? Okay.
This conference will now be recorded.
Assalamu alaikum.
Walaikum salam.
Okay, Dr. Saima.
Yes, sir, I'm ready.
You will still need 2 minutes or no need for the 2 minutes?
Just 1 minute.
Okay, I will adjust time for you.
Okay.
Okay, I will adjust 2 minutes. Okay, no problem. Take your 2 minutes. I will adjust. Start. Okay. I will adjust the 10 minutes, please.
Okay. Hello, I'm Dr. Saima. I'm one of the senior doctor in the labor ward. May I confirm your name and age? Do you need any pain relief?
No,
How
doctor,
are you
thank you.
coping? Okay, how are you coping?
I have liver pain, doctor. No coughing. I have liver pain.
Okay, I can arrange some pain relief if you want.
No, doctor, I can cope with that. Okay.
Okay, should I continue?
Yes, okay, doctor, please.
Okay, I am Dr. Saima. I am one of the senior doctor in the labor ward. May I confirm your name and age, please?
My name is Sarah John, and I am 27 years old.
Okay, can I call you Sarah?
Yes, doctor.
Okay. Okay, Sarah, what I gathered from your notes that you came with labor pains and you have previous one cesarean sections and now you are offered cesarean section due to the bottom down position, baby bottom down position. Am I right?
Yes, doctor, you are right.
Okay. Okay, Sarah, I will ask you certain questions to know more about you, and then I will give you information about the cesarean section so that we can reach a mutually agreed plan. And if you agree, then at the end of the discussion, you may sign the consent form. How does it
No,
sound?
doctor, I don't want to have cesarean section. Why you will offer me cesarean section?
Uh, Sarah, because your baby is bottom down position and you have you have undergone one cesarean section previously and the baby has passed the bowel inside the baby has a bowel movement inside your uh, tummy, so we are doing cesarean section for the safety of your baby.
So my baby is not well now inside my tummy. My baby is suffering
Because
now.
baby has past meconium and the position of the baby is such that it needs a cesarean section because sometimes the cord may come out and it may compress the blood supply to your baby and the baby life can be in danger.
No, doctor, I hate this cesarean section. You don't know what
Uh,
happened for me in the previous one. I don't know. I
Sarah,
don't want this
can
one.
can you please tell me why you don't agree for the cesarean section?
Yes, doctor. In my previous surgery, it was a horrible experience. I came in the hospital after my labor started alone, and they monitor my baby, and suddenly they push me in the theater, said my baby also is suffering, and they did surgery for me. After that, no one come to talk with me about what happened and why they offer me cesarean section. And I get an infection in my wound, which it take time to heal. So I don't want to have this experience again.
I'm very sorry to hear about that, and I'm very sorry that the things did not go with your expectations previously. But I am also very concerned about the safety of your baby, and I also understand, and I am sure that you are also very much concerned about the safety of your baby. What do you say?
Okay, doctor.
Uh, can you ask you a few questions to know more about you?
Okay.
Okay, why your previous cesarean section was done?
They said because my baby suffering in my womb.
Okay, and I read from your notes that you had some bleeding problem.
I have
Some bleeding problem in your previous pregnancy.
no problem at all.
Okay, and what you told, what they
Yes,
told you
I
about
have
the.
bleeding. I have bleeding, and after that, my baby is suffering. Also, rush me to the OR.
Okay, and how your baby doing now?
He's fine.
Okay, nice to hear that. And were you transfused any blood previously?
No, no.
Okay, what is your blood group?
All positive.
Okay, and do you have any other medical disorders?
No at all.
Okay, do you have any drug allergies?
No.
Have you ever undergone any surgery before, apart
No,
from cesarean section?
this is my only surgery.
Okay. Uh, so, Sarah, we are offering you cesarean section because we think that it is safest for your baby. And I want to tell you what this procedure involve. In this procedure, we will give you analgesia in the form of either we will give you spinal anesthesia, in which some medicine will be injected by a needle into your spine, or you will be put to sleep by some medication, and then we will make a cut in your lower tummy, and the baby will be removed. And most of the patients don't have any complications, but like any surgery, there are some risks, and we divide these risks into serious and frequent risks, and I want to tell you about them in more detail. Are you with me?
Yes, I am following you, doctor.
Okay. There is small risk of infection, small risk of bleeding, and small risk of small risk of infection, bleeding, and a small risk of injury to the viscera like bowel, bladder, or ureter. Because you have previous one surgery, so one cesarean section, so this cesarean section can be more risky than the previous one. And in some even I want to tell you about the serious risk that in rare circumstances, even we have to remove the womb because of extensive hemorrhage, or sometimes death might happen. And
So,
I am arranging your appointment with the anesthetist, and the anesthetist will discuss all the options of pain relief with you. And do you have any questions?
why my baby has passed this meconium, and what does it mean?
The baby has passed the bowel movement inside your womb. Sometimes when the baby is in bottom down position, the bottom is compressed by the veins or your pelvic bone, so that it might pass the meconium. So we will we are monitoring your fetal heart rate to see either the baby is doing well or not. And I'm providing you the patient information leaflets about the delivery of each baby as well as for the cesarean section. And you can read these information leaflets and you can make up your mind. And if you are agreed for the cesarean section, I will sign here on the consent paper that I have provided you all this information. And if you are agreed, you will also sign on it.
Okay, doctor. Can we wait till my husband arrive? I can't take consent alone. I can't take a decision alone. I have to wait till my husband arrive.
Okay, we can wait for some time till your husband arrive. Till that, you can make up your mind, and we will monitor your baby continuously to know that your baby is healthy and well.
Okay.
Do you have any questions?
No, doctor.
Okay, thanks.
Thank you. Thank you, Dr. Asaima. Well done. You managed to finish with time, and you till the end, and you take the consent of the patient. You did well in this task, just in time. Yes. You cover all the point. You ask about the recovery of the patient in the previous surgery. You ask about her baby, and you ask about her current pregnancy now. You take the history in systematic way. Very good. The only thing I can comment in your task is taking the consent. Taking consent is an art, and you have to show the examiner that you are in a real situation and you are now taking the consent of the patient. So there will be a consent of the cesarean section there, and you will hold this consent and write the patient name and her date of birth in the consent. So you will act as you write the patient name and her date of birth, and you will go in the consent item by item. So you will ask her about the operation. What do you know about the operation offered? Whether she has any idea about the cesarean section or no? What is the benefit and what are the risks? We are going now to discuss all of this. And at the end, you have to give the consent for the patient to sign here, and you will sign opposite to the patient as you give her all the information. So you have to hold the consent in your hand and assume that you write the patient name and date of birth and explaining the consent of the patient. Otherwise, you did well in covering all the point in the scenario. Also, one point I wanted to comment: reviewing the patient note. You have to tell the examiner that I wanted to review the patient notes, previous notes, to see how was her surgery, whether there was any complication during her surgery or no. What is the type of the incision she did? She may have a classical uterine incision. She has any blood transfusion, any complication, blood angel, oil angel. You have to know what happened. Uh, you may also find any recommendation from her previous surgeon. So you have to review the patient notes. Also, her notes in this current pregnancy to know more about her the placenta, the site of the placenta. There may be placenta brevia or like that. Otherwise, you did well, and you gain the patient in your side when you respect the patient autonomy and tell her that you will not do anything without her consent. This was also very good from you. So regarding this scenario, you may find this scenario taking consent for cesarean section, taking consent for instrumental delivery, taking consent for stethoscope. Anyhow, this one of the tasks came before in part 3 of examination. You will greet and deduce yourself. Very, very good point when I assume or when I act that or when I mock that I have contraction in the start of the station and you stop, don't speak at all till I finish my contraction, and after that you offer help. It was very, very amazing from you to do that, because all of us may forget to do that, and we want to go directly to the station or to the task to finish before the time will finish. No, this will be you will lose your mark here in the patient safety. So when the patient cries, stop till the patient finished cry. If the patient has labor pain, don't talk at all till the patient finish her labor pain. And because she is in breech and footling in labor, or even if the patient has preterm labor, don't say well done or good or anything like that, because no, it will not be reasonable in this patient, because you want to do for her cesarean section. But if the patient will aiming for vaginal delivery and the patient has contraction, so you can tell her, well done, good, you are doing well, like that. But this patient is footling, or if the patient also have preterm labor, don't say for her, well done, like that. So you did well. It was very amazing point from you to stop till I finish and offering help. Do you want any painkiller for that? I said, no, I can manage. Okay, we can continue. Introduce yourself and confirm the name and the identity of the patient. Then check the purpose of the meeting. Understand that you are here today because you are in labor and your first pregnant and your first baby by cesarean section. And according to the examination done for you, your baby is coming feet first. Am I right? She will said yes. She will said yes, doctor, but I don't want to have cesarean section. So good that you ask her about why you don't want to have cesarean section. If the patient refuse anything, you have to ask why. If the patient want anything, also you wanted to ask her why. Sarah, I totally understand your concern. I wanted to assure you that I am here today to answer all your questions and address all your concern. At the end, the decision is yours. Here, you respected the patient autonomy and you gain the patient to your side. So the patient now assured that nothing will be done against her decision or against her autonomy. So the patient doesn't want to have cesarean section. I totally understand your concern. I am here to address all your questions. I am here to answer all your questions, and at the end, the decision is yours. But could you tell me why you don't want to have cesarean section?
We can't hear.
Hello? Hello? We can't hear anything.
Dr. Ali, no voice. Hello, Dr. Ali? We can't hear anything. It's completely mute. We can't hear you, Dr. Ali.
Yes. Sorry, my colleague. It was a connection error. My voice clear now?
Yes, yes, now we can hear.
Yes.
Okay. Okay. I'm gonna start to record again.
This conference will now be recorded.
Okay, again, after greeting and introduce yourself to the patient, confirm the identity, and you check and confirm the purpose of the meeting. The patient will say that I don't want to have cesarean section, and she will say because I have a wound infection like that. Sarah, I am so sorry for that. Sarah, I am sorry if you find the care that you met didn't match your expectation. Infection can happen after a cesarean section, especially if it was emergency cesarean section. But every delivery has its own situation, and we will try to prevent that by giving you antibiotic and strict hygiene. No, doctor, I wanted to have vaginal delivery. Here you have to explain why you offer her cesarean section and why the vaginal delivery will not be the safe method for her delivery. Sarah, as your baby coming food first, the vaginal delivery will put your baby at a risk. After delivery of the body of the baby, the head may stuck inside your tummy, and this may cause serious risk for your baby, like fracture of the bone or head or brain injury, and even death. And so the research found that cesarean section is the safest method of delivery of your baby in this situation. So, in checking the purpose of the meeting, you will check that the patient is now in labor and her baby is coming feet first, and she was offered cesarean section. The patient will say, no, I don't want to have cesarean section. So you have to ask her why. After respecting her autonomy and reassure the patient about her autonomy, ask her why, and she will say that I have like that, I have a complication. Show sympathy with the patient. Show sympathy with the patient. I am sorry to hear that. I'm sorry if you find the care that you met didn't match your expectation. But we will try to prevent that by giving you antibiotic and they will do strict hygiene. We offer that cesarean section because of like that. Because of what? Because the vaginal delivery will be risky for your baby. The head of your baby may stuck after the delivery of the body of your baby. So the research said that cesarean section will be the safest method of delivery of your baby in this situation. She will say, yes, okay, doctor. Like here, you will start to put the agenda of your discussion. Sarah, I am here to discuss the consent of the cesarean section. I will explain what cesarean section mean for you and for your baby, and what are the benefit and the risk associated with this surgery. And at the end, if you make your mind, you will have to sign the consent here, and I will sign here as I give you all the information. Is it okay? She will say okay. Then you will ask her about take a relevant history or quick history from her. Before we taking the consent, I want to ask you some question to know more about you. Is it okay? Ask about the current history or current obstetric history, how far, what was any scan she offered, any test she offered before, the past surgery, why she offered the section, as you asked Dr. Asaima, very good. And how was the recovery? You have to ask about the recovery. Ask about the baby. So you have to ask about the pregnancy, the delivery, how was her delivery, why she offered section, the recovery, and her baby. Then go through her remaining history as you know, gynecological history, medical history, any allergies at all, any smoking, social support, and any family history. Thank you for sharing this information. With your permission, I wanted to review your notes. It is very important point in this task to review the patient notes to know whether any concern in her cesarean section, any recommendation from her surgeon. At that time, you will hold the consent in your hand. After finishing taking the history of the patient, you will hold the consent in your hand and you will confirm the patient name. Excuse me, let me confirm your name and the date of birth, please, again. She will say, I am Sarah John, I am 27 years old, like that. And you will act as you write in the consent. Okay, Sarah, do you know the name of the procedure that you offered? She will say, no. Okay, this is a cesarean section during which there will be a cut in your tummy and womb to deliver the baby and the placenta under anesthesia. Sarah, we will do that because we believe that it is the safest method of the delivery of your baby according to your situation. This is the benefit. This is the benefit of the surgery. As you see here, this is the consent for the cesarean section. Okay, here is the name of the procedure. It will be empty. It will be empty in the exam. Okay, here the benefit, it will be empty, and you will assume or you will act as you write here. Also the risks, it will be empty and you will write here. Okay, so in the name of the procedure, you will come, do you know the name of the procedure? She will say, no. Okay, it is a cesarean section, during which there will be a cut in your tummy and womb to deliver the baby and the placenta under anesthesia. Okay, in the benefit, you will not say to her, do you know the benefit? No, go direct to the benefit. We will do because we believe that it is the safest method for the delivery of your baby according to your circumstances. Then you will go to the risks. Sarah, most of the women will have this cesarean section without complication. However, some women may have a complication from the surgery. But we have our measure to reduce these risks. We can categorize these risks to frequent and serious risks. And you come under the frequent risk, and you mention some of the frequent risks of the cesarean section, as you know from the consent advice. You are likely to have your baby in the next pregnancy by cesarean section. You may have a hemorrhage during the surgery, and we can give you some drug to stop it. And there is a risk of the infection about 6 in 100. If you remember the figure, it's okay to mention it. If you don't remember the figure, okay, don't mention any wrong figures. Infection in the wound can happen in 6 in 100, and you will be given antibiotic before the surgery to reduce that. There may be a risk of the cut of the skin of your baby, which usually heal in a few days. This may happen in 100. Regarding to the serious risk, sometimes some women may have a clot in the leg or the lung, and you may be given blood thinning agent according to your assessment. Okay, so you mentioned the risk and how to protect her from this risk. So now the patient may be some assured or safe. There may be injury to the bladder or the bowel, and we may need input from the other surgeon to repeat it. Sometimes we may need to remove the womb because there may be a bleeding, severe bleeding, and nothing to be done except the removal of the womb. This is called the emergency hysterectomy. Also, you may be given blood transfusion in case of the bleeding. And here you have to ask her about the concern of the blood transfusion. Don't forget that. Any concern regarding blood transfusion, she will say, yes, doctor, I don't want to have blood transfusion. Here, you have to ask why. Why you don't want to have blood transfusion? She said, I'm Jehovah's Witness, doctor. Okay, so which type you don't want to have? She will say, oh, the type of the blood transfusion I don't want. Okay, you have to explain for her the risk of denying blood transfusion, why she doesn't want. But okay, she is Jehovah's Witness, and what are the risks of don't have blood transfusion in case of the bleeding? Don't say okay and I will document. As we said before, you have to explain the risk, why she doesn't want to have blood transfusion, and what are the risks associated for refusal of that. Sometimes blood transfusion will be inevitable and life-saving. But if you don't want to have blood transfusion, I will document this clearly in my notes to my colleague, and I will communicate with the blood bank to know whether there is availability of the cell sulfage where we will use your own blood. Now the anesthetic doctor will come to talk with you about the method of the anesthesia. We have two types of the anesthesia, either regional one, where the drug will be injected in your back to numb the lower half, or the other one where the drug injected in the vein in your arm, and you will be sleep during that one. Am I clear? Do you have any question? She will say no. Do you agree? Are you agree for the section? She will say no. Okay, now I will give you patient information leaflet, and you will have to sign here, and I will sign here. The patient may ask you, as I asked my colleague Saima, I wanted to wait for my husband. According to your notes, the CTG is normal, the tracing of your heartbeats is normal, so no problem to wait for your husband for some times, and during which you will read this patient information leaflet, and I will give you antacid and antiemetic analgesic, and we will continue for monitoring of your baby. Is it clear? Any question?
Sir, in this case, the patient is already in labor. She's 3 centimeter dilated. Still, we have to offer her patient information leaflet.
Yes,
Usually,
this patient exactly. She in the exam she asked to wait for her husband, and she is now early in labor. She is 3 cm, and we can wait for her husband till he arrive. We can wait for 30 minutes, and during this 30 minutes, she can read this patient information leaflet to know more about her surgery, and if she has any question, if she has any concern. No problem to read the patient information leaflet. She is in labor, and we will wait. We will not push her now to the theater.
okay, so in emergency also we can offer her pill, no problem, right?
Yes.
Thank you, sir.
Welcome.
Hello, Dr. Ali.
دكتور حسام تفضل.
Please, in such a station, if this patient came without rupture membrane, with intact membrane, can we offer here external cephalic version as one choice if she insisting to have vaginal delivery, for example?
I think Fotling not be or sorry, Fotling is a contraindication for extracephalic version. I think like
In
that.
guidelines,
It's not so.
in guidelines, they not mention footling contraindication. It's can be done, but in case the membranes intact, it's not contraindication
Okay.
for cephalic version.
Okay. Okay. So if the patient, if this not mentioned in the guideline and this is not contraindication, and you are sure from this point, so you can offer for her the external cephalic version, no problem.
And
But
I
this
think
patient,
she is early in pregnancy. Yani if she is
what?
not, if she, I think she is early in pregnancy, and if she came without rupture
Early in
membrane, and
labor,
there is
yes.
any, and there is no
Yes.
any permanent cause for repeat cesarean section, we can offer her this option. Okay.
Yes, it's okay. It's still extracephalic version can be done even if the patient came in early labor. And the previous cesarean section not contraindication for external cephalic version, as I remember from the guideline, but I didn't remember this Fotling is contraindication. No, you now confirm that it's not contraindication. So you may offer that for the patient.
Okay. Thank you.
Yes, but in the scenario in the
Hello?
exam
Yeah.
they will reach with you till this point, because the the task about how to take consent. So for the cesarean section, and the examiner wanted to know from you how you will take consent from the cesarean for cesarean section. So you will not the role player will not reach with you till this point of external equivalent version. She will not insist for that, and she will agree with you for the cesarean section because she is prompted for that. She is prompted to not to insist, to refuse, because we wanted to assess the patient, the candidate for how he take a consent for the cesarean section.
Dr. Ali, as a general rule, if the patient gives a consent for example, doing CS or operative vaginal delivery at any time during labor itself, she can withdraw her consent and proceed for CS, for example.
If the patient give consent before, she may change her mind at any time. No problem.
Okay.
Okay.
Hello, Dr. Ali.
Dr. Salma, yes,
Hi.
welcome.
Yeah, thank you. I would like to ask you one thing, that you explained that why you will do the cesarean section, that your baby may stuck in the the vagina, so it will be problem. So that's why we will do the cesarean section. So we can explain this one also, that the footling, there is a risk of 5% that there will be cord prolapse.
So it is also life-threatening. So to avoid this, also may need for cesarean section.
Yes, you have to explain for her what is the footling mean for her and for her baby. What does it mean for her? The footling is the contraindication, as you know, for vaginal delivery. The breech, they put some precaution or some criteria for the patient who can have a vaginal breech delivery. One of them, the footling wasn't in this criteria. So you have to tell her why we don't prefer for her the vaginal delivery. By your means, by your word, as you like.
Yeah. So another thing, so you ask that why this meconium, what will affect? You ask the patient. As a patient, you ask
What?
the
The
you ask
patient information?
no, you ask her that this meconium, how it will affect, isn't it? To explain the meconium.
Yes.
Yeah.
As Dr. Saima explained exactly, sometimes the baby who come feet first, they may open her bowel inside the tummy, and it doesn't. This in your situation, this is no harm for your baby because the tracing is normal, so there is no problem for your baby from this.
Mhm. This is enough.
Yes, this is
This
enough.
is enough
Yes,
to explain. Okay, thank you.
yes.
Thank you.
Welcome. Okay. Who wanted to share the next one?
Can I try?
Okay, Dr. Aisha.
Yes.
Dr. Aisha, you did a case in the last session. Am I right?
Yeah. Yeah.
Okay, we can give a chance for the other colleague if they
Yeah,
wanted to
sure.
share. If no one wanted
Yes.
to share, it's okay for you to do that.
Okay. Okay, no problem.
Can I try, Dr. Ali?
Yes, sure, Dr. Anila.
Yes.
Okay, welcome. Okay, you have 2 minutes.
Okay.
You have 2 minutes. 2 minutes
Okay.
to read first.
No, the slide changed. This is case 11?
This is case 11, yes.
Okay. Oh my goodness, labor ward prioritization.
No problem, no problem. Try. This is the CTG for the cases, Dr. Anila.
Okay. 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 Are the 2 minutes over? Okay, now.
Okay, 2 minutes now over. I will adjust for you that 10 minutes. Please
Okay.
wait.
Okay, sure.
Okay, start.
Okay. I'm Dr. Anila, one of the exam candidates, and I'm ready for the discussion.
Okay. Doctor, you read the instruction outside the cubicle, and now just your colleague has finished the handover of the labor room for you, and you received this 6 patient in the labor room. So, tell me how you will manage this case and justify your answer, please.
As a quick look, when I see at the 6 rooms, I think that, in my opinion, there are 4 rooms are semi-urgent and 2 rooms are routine, and I yet have to see the CTG of the rooms, and then some of my semi-urgents might get converted to urgent. So now I would like to have a look at the CTGs.
Okay.
So room 1 is the previous cesarean section, and she's at 3 centimeter, and the CTG spontaneous labor is showing recurrent decelerations. Variability is good, and so I would consider her still consider her urgent, and I have to do the ARM for her. So then the room, which other CTG is this for room 3? We have a CTG as well?
Yes, this is for room 3.
Yeah, the lady who was induced and membranes were intact. So room 2 has basically no variability and no contractions as well. So this room 2 needs an ARM to be done. So this is also urgent. And this previous IUFD, room 4, I've written her as routine. And then room 5 is the Paris lady in spontaneous labor. Meconium at 6 centimeter, and the CTG is given here. So her CTG is fine, and she is in labor, so I will keep her in the semi-urgent. So the 2 urgent cases that I have, I think, are the one with the previous cesarean, which is room 1, and the other one is the room 3. And the last patient also, I would take her as a semi-urgent. She is delivered, although she has 2500. Drain contains 2500, sorry. Second stage cesarean section, given her Meo's drain is 2500. Sorry, this is an urgent. So then I will say that the 2 urgent cases are the room 6 and the room 1, because I'm suspecting, there could be, I should be very careful about this scar. So the staff I have, given the staff I have, I would request this consultant anesthetist to go to room 6. And then I will inform my consultant to be with me because we have 2 urgent cases. I will myself go to the previous cesarean, and the senior midwife I will send to, we have 4 midwives. So one midwife goes to tell the previous IUFT, just do her CTG and tell her that we have other high-risk cases ongoing that we have to manage, and just assess the selective cesarean can be withheld for some time. And so I go myself to room 1 and quickly to membranes intact and do her ARM, and then leave the ST2 there to monitor her progress. And Then I go to room 2 myself. 38 plus 4 for IUGR. Room 2. Room 2 CTG is not there. All normal deliveries came for, so this is also for induction. Okay, so she can also wait. The other midwife can go there and tell her that she can wait. And then this room 3, where the priming gravida, I will send this senior midwife there in room 3, who can just do and offer an ARM to the lady and tell her that we are concerned because her fetal heart is, we have a concern about the fetal heart. It's not as much good as we should be expecting, and we need to know, and the ARM will help us to know if there's an acute distress or not. And then the consultant might have to take this room 6 for re-exploration. That's why the consultant has to go there, join the consultant anesthetist. And because 2500 ml blood drain is quite, this is a massive obstetric hemorrhage that has happened here. So this is what is. I'll go to room 1. The consultant anesthetist I will request first the ST5 and the consultant anesthetist to join them there and inform my consultant who also joins them there, because there's going to be reoperation. And then the ST2 can also join them and take the consent for the re-exploration and explain to the patient and the attendants. And then the routine cases can wait till the other cases are dealt with. And then the other 2 cases I'm concerned about is the room 1 and room 3. So this is my impression.
Okay.
Yeah.
Anything else? You still have time. You want to add anything? You still have 3 minutes.
Yeah, so I have to inform the theater staff that we might have to bring at least 2 cases. The one is definitely coming. Room 6 is coming back to the theater. So I have to inform the theater coordinator. And the coordinator midwife has to be alert as well. And for room 6, we have to tell the blood bank, the hematologist, because we have to send 4 to 6 units of cross match for her and make sure if she's not a Jehovah Witness. And then in that case, we have to arrange for the intraoperative cell salvage. And for room 1, which is a previous cesarean, also we have to discuss with her the possibility that we might have to take her for an emergency cesarean section again, because we can't wait longer, and we would be concerned about the the scar rupture. So I will take the consent from her as well and keep her informed. And also we need to discuss the Jehovah Witness thing with her, group and save, and send a cross match for her as well. And for room 2, she's room 2, all normal deliveries came for IUGR. For her, we will do the CTG and see how the baby is doing right now. And of course, we offer her the apologies. One of the midwives can do that. And room 3, I said that I'll send my senior midwife there to offer the ARM and do the ARM and then see how the CTG responds. And then I join her there as well. Room 4 will be explained that after the CTG, we'll just hold on. And room 5 is doing well. One of the midwives can carry on with her labor. So this is, meconium is there, but we will still, she can inform us. Are there any MEOS chart available? Because it said that MEOS chart are available. That was for room 6. So for now, this is the immediate planning that's coming to my mind.
Okay. Well done. Well done, Dr. Jamila. Still have time, but you managed to finish with time. Really,
Yeah.
labor ward prioritization is very tricky task, and in the exam you may not find time to finish all the scenario. This task is relatively easier than the task who came in our exam. In our exam, they gave 8 scenario, and from this 8 scenario, there were 3 patients in urgent case. It was 2 patients with bleeding and 1 patient with pathological CTG. But this task is relatively easier than the one came in our exam. But anyhow, you did well, and when you manage the remaining time, you finish before the time by 3 minutes, and when you use the 3 minutes, you add more information. So if you finish your discussion before the time and you still have time, talk. Don't stop. Still, you will mention some point which you will take mark for her. If you mention the consent, the blood bank, the laboratory, the consultant, any point you will mention, you will take point for her. So don't stop. You still have time to mention what is in your mind, what you will do for this patient. Still, you can take marks for this. And 1 mark may make you pass this exam, and 1 mark may not you fail in this exam. So don't waste your time and get benefit from your time. If you finish early, don't stop. Talk till you hear the sound outside. Okay. But in the exam, I am in doubt that you will finish before the time. You will talk till the sound will alarm. So in this task, you have this task came to assess your ability to how to use your stuff, or how to assign your stuff, and to know how you will prioritize the patient in the labor room, which case you will start. In the labor room prioritization, you will start usually by the case who have vaginal, who have bleeding. Any patient who is bleeding, this will be the most urgent one. So to make it easier for you, usually do labor room by SPAR tool, by situation, background, assessment, and recommendation, and go room by room as you did. Go room by room, and after you finish 6 room, so say I will start by room 6, I will start by room 3, like this. So do it by SPAR tool and go room by room. Categorize after you will do the SPAR tool. Categorize it to urgent, semi-urgent, or non-urgent. Assign the stuff according to their description. And finally, after you finish all room, you can arrange them according to the urgency. So you will say, I will start by room 6 or by room 1. This is 6 patients. In our exam, there was 8 patients. 8 patients. I think it was too lengthy scenario. If you didn't finish reading outside the cubicle, you can take some time inside to finish reading. So you can say, excuse me, sir, can I take 2 minutes to finish reading the instruction? He will say, okay, no problem. It's your time. Even in the simulated patient task, if you didn't finish reading outside the cubicle, because only 2 minutes, and there were 8 patients, and all patients with a lot of information. So if you didn't finish, better than to go in the scenario and you didn't read an important information. So you can complete reading inside the cubicle. You can say, excuse me, can I take 2 minutes to finish reading, not to miss an important point? He or she will say, okay, no problem, it's your time. Okay, so in first patient, I will do case by case. The first patient was room 1. It was previous one cesarean section, term, now in continuous labor, giving her CTG as 3 cm and intact membrane. This is her CTG. It show early deceleration, and this patient is still in early labor. She is still in the latent phase. So according to the situation and the background, this is previous scar in labor. According to the assessment, the CTG show early deceleration. What you will do here, the action, what you will do, I will assign one of the midwife to go to this patient and to continue the CTG and do ARM for this patient. As you mentioned, you can do ARM, artificial rupture of the membrane, and report me back about the color of the meconium and any changes in the CTG. This is a semi-urgent case. According to room 2, this is para 5, multi-para, all normal delivery came for IOL at 38 plus 4 weeks for IGR. Okay, this is non-urgent case. This is the situation. Multi-para came for IOL for IGR. No assessment till now. I will assign one of the staff midwife to take relevant history from this patient, like the baby movement, to do the routine labs like CBC, group and save, and do CTG. And as you mentioned, apologize for the patient for any delay. This is non-urgent case. Case room 3, this is a prime gravida and used for post-date, and after that she was 2 cm, and after 4 hours 3 cm, but her CTG, as you see, is pathological CTG because there is decreased variability. So this patient, prime gravida induced for post-date in latent phase. According to her assessment, she is in latent phase and CTG show decreased variability. The recommendation I will send for her the ST2 to start the conservative measure and do ARM for this patient, continue the CTG, and communicate with the mom, he or she, the ST2 make take consent for cesarean section if the CTG is still pathological after the conservative measure. This is an urgent case. So the ST2 can go to this patient because the ST2 can take consent for the cesarean section. So he can start the conservative measure, start to do ARM, communicate with the mother to take consent if it's still pathological CTG. Regarding to room 4, this previous IOPD patient came for elective cesarean section on her request. As you see, this is an urgent case, non-urgent case at all. So I will send the staff midwife to take relevant history and to take the routine perioperative lab and apologize for the patient for the delay. The ST2 will come later to take the consent. The midwife can't take consent for the cesarean section. The ST2 can take. So the midwife will apologize for the patient for any delay from the ST2. He will come later to take the consent. This is non-urgent case. The room 5, this is Paras in spontaneous labor, meconium stain, and her CTG is normal CTG, meconium at 6 cm, but normal CTG. So I will send one of the staff midwife to alert the pediatrician to attend the delivery. This is meconium stained baby, so the pediatrician have to attend the delivery, continue the CTG, and to inform me any concern about the CTG. This is a semi-urgent case. Room 6. The case of the bleeding. So this is the most important one. This is post the second stage cesarean section with likely internal bleeding because she has 2.5 liters blood in the drain and the mute chart deteriorate. Sorry, I didn't write here that the mute chart deteriorate. So this patient, I will do bleep for massive obstetric hemorrhage. I will call for help from the consultant, obstetrician, consultant, and registrar, anesthetist, alert the lab, the blood bank, the senior midwife, communicate with the mom, take consent for possible reopening again, exploration, and start the resuscitation of the mother by airway, breathing, circulation, give her fluid till the blood is available. This is an urgent case. So at the end, you will arrange the room 6. It is the most urgent case. I will go by myself here and I will call the consultant, as we said. In the room 3, also it was urgent case. I will send the ST2 to take the consent from this patient for the cesarean section if the CTG is still pathological. Like this. This is according to the labor room prioritization. It is easy task, but if you go systematic, if you are afraid from the task and you didn't finish reading, it may be horrible for you and you lose this task. Any question?
Yeah, I always find this very difficult. Labor ward prioritization.
I know it is a tricky task. If you did it for the first time, it will be difficult for you. But
Oh, it seems
yes,
like it
after.
seems like it starts sending shock waves to the brain.
Yes, I know. Like this. In our exam, it was eight scenario, and it was a lengthy task. I didn't finish reading the task outside the cubic, and I still reading inside
Sir,
the cubic. Yes, like that.
But
It
this
was
table is
lengthy.
very good. The table that you made, this table is very good. I hope we can see it in the recordings as well. This table that you made is too good. This table.
Yes, you can go by the SPAR tool. If you did this by this method in the examination, they don't want from you how to manage. No, they don't know what you will do. Some of our colleagues say I will for example for the patient with IGR like that. IGR like this. Yes, some what is IGR? I came for I yes. They say I will review her ultrasound. I will review her investigation. No. I will see the Doppler. What is SGA or IGR? No. There is a decision taken for this patient. Already she came for induction. You will not change the now the plan of the patient, and you will see the Doppler, and you will see the investigation and the ultrasound. No, she want from they want from you only how to prioritize the patient, which patient will start, how you will use your stuff. You have ST2 and you have staff midwife and you have senior midwife. How you will use this stuff, not not how to manage all of these cases.
Thank
Am
you
I
so
clear?
much. I think others will
Dr.
be
Ali,
looking
دكتور
to.
علي
Yeah, thank you so much.
Welcome.
دكتور علي
uh,
دكتور علي
Dr.
doc-
Hussein, اتفضل.
Yeah, I want to ask one question. I think this is the best strategy to follow in exam to take room by room, and in the end, if we have time to recap and put the rooms in order of prioritization. But is a question here. I am afraid that if I started to discuss room by room, the examiner will interrupt me and discuss each room separately, and this may waste time because I noticed that you didn't interrupt Anila during her explanation. In real exam, he will let me to talk the whole 10 minutes, or we can interrupt me and ask me regarding each room because this will waste the time.
Yes, I understand your question, Dr. Hussein. Really, I will talk about my experience and our colleague experience. No one said that the examiner interrupted him at all in this task, because the examiner wanted to hear from you what you will do for each room, and which room at the end will be the most important and the priority for which room. So the examiner will not interrupt you, as also the examiner know that this is a lengthy task, and you will hardly manage the time to finish all the tasks. So there is no time to interrupt you. If he interrupt you in one scenario, so the 10 minute will finish in this scenario. If he catch anyone and ask you about the IGR and how you will do induction and which patient and what is the Doppler and like that, no time for all of this, I think. And according to my experience, no, the examiner keep listen to our talking, no interruption at all, and at the end, no one finish the 8 cases.
Dr. Ali, excuse me.
Yes.
Dr. Ali,
Yes, Dr. Adipti. Yes, I'm
Yeah,
hearing.
Dr. Ali, I just wanted to ask you, for induction of labor, which are the blood tests, lab tests we have to ask for? Because I'm not sure about For normal delivery, we don't do anything, I believe. Like that, we don't have any orientation. If patient is low risk and coming just for delivery in spontaneous labor, should we offer some test? Or patient who is coming just for induction of labor, which test we have to recommend? Lab test, I mean, and patient who is posted for cesarean section, which are the lab tests we have to ask for? Can you just brief us about that?
Yes, according to our colleague working there in the UK, after discussion of this with them, they said if the patient came for induction, only they will do CPC and group and save. CPC and group and save. And if the patient came for cesarean section, they will do CPC coagulation profile. Coagulation profile. This is the most important, and the group and save also. So we'll add coagulation profile for the cesarean section. So for the induction of labor, only CBC and group and save.
And for normal
Sir, what is
spontaneous
the
labor
role?
patient?
Even in normal, for normal, I don't know really if the patient came in spontaneous labor, what they will do. But I think there will be group and save, sure. But I
Dr.
don't
Ali,
know about the CBC. Yes.
what will be the role for senior midwife? Like, what is her role? I mean, in this scenario or even otherwise in prioritization, where do we place?
Yes,
I
this is
find
a table I did for the job description for the staff. We have in the UK FY1, FY2, the foundation year 1 and the foundation year 2. This is after the school, medical school. This
yes, sir. Thank you. This
junior
is
doctor can do can take history, do examination, and can insert the cannula, take blood test, and
yes, this
apologize
is
to the
very
patient.
useful. But
Yes. For the after that,
okay,
there will be the ST1, ST2, ST3,
ST1.
ST4, and ST5. ST1,
Okay. So the senior midwife, where do we send in the
yeah,
present case scenario? Senior midwife, sir. What will be the role for senior midwife in the present case
yeah.
scenario?
The senior midwife, it is the coordinated midwife. Coordinate. It is the one coordinate and to also assign which midwife will go here and there. So
Okay, sir.
you
So
have
she will
staff.
be the one for coordinating cesarean and the OT.
Yes, you can coordinate which staff midwife. You have four staff midwife, and you have senior midwife. This is the coordinated midwife. She will say
Okay.
one from this staff midwife to go there. So you will ask when you want one of the staff midwife to
Okay, sir.
go. You will
Okay,
ask
thank you. Yeah.
the coordinated midwife to tell them. So you will communicate with the senior midwife
Okay.
to tell the staff midwife to go
Okay.
here and there and like that.
Okay. Thank you, sir. Thank you.
Sir, here in this case, room number 6 can't be sent anesthetist registrar because it's a post-op patient anyway. So can't we send anesthetist registrar to see this patient? Gradation will be
You will ask.
urgent, but yeah, can we send, because most of the times I have noticed any post-op patients usually we are sending anesthetist.
You ask about the anesthetist.
It is to see the patient like that
Yes, you can ask it.
because
You
it
can
is.
tell. I will call the anesthetist to come to assist the patient. No problem, and they can help you in the resuscitation. It may be difficult calculation. The
Yes,
patient
yes.
may need the resuscitation. So if you say any word, you have to justify. Justify for what?
Okay, okay.
Excuse me.
Okay. Yes.
Uh,
Yes.
regarding room 3, do we need to consider fetal blood sampling?
Room 3. Primary gravida. This one.
With pathological
Yes.
CTG, and she's still
Yeah,
3 cm.
Take blood sample.
Do we need fetal blood sample? Yes.
Yeah, fetal blood sample. Fetal blood sample, I think it will be done after 4 cm. This patient is still 3 cm. In the strategy, they mentioned that fetal blood sample not be done at a very early labor like 3 cm. She can be done after 4 cm. So they didn't prefer to do fetal blood sample in this stage of early labor. Yes.
Okay, okay. Thank you.
Okay, Dr. Abara, welcome.
Dr. Ali, can I ask
Thank
you a
you.
question?
hello, Dr. Ali.
Yes, Dr. Ala, اتفضل.
Really, I want to speak about this same one what she said, Doctor, before about the fetal blood sampling for room 3. We categorize room 3 as urgent and room 6 as urgent. And in the staff that we have, the consultant did not say that away or he will come after 30 minutes or something. So the consultant, I think he is available. Why he is not going directly to room 6? And I will go to room 3 because he may need also cesarean section for this CTG and fetal blood sampling is really in this. They said not below 3 cm, but now the cervix is 3 cm. So how you will say?
Yeah. If the consultant is already here, okay, the consultant will do the room 6. He will manage room 6. He will do the exploration for room 6 and the opening, and I will go to room 3 to do the cesarean section because the ST2 can't do cesarean section alone.
Yeah,
The
this
ST2
what I okay.
Yes, the ST2 can do cesarean section under supervision from the ST5, like you. So after the consultant will came here in room 6, you will leave the consultant and go to room 3 to help the ST2, or the ST2 will help you in this task.
Yeah, but my point is because in the scenario you did not say that the consultant away. So is it possible to tell my consultant to go directly to room 6 because it's urgent, and I will go to room 3 because I think this ST2 the
Yes,
need
but if
more than
here he didn't
the
mention that the
ST2
consultant.
ST2 level because may need fetal blood sampling or CS or something like this.
Yes, but here they didn't mention that the consultant is already in the hospital or he is away. But as I know, the consultant will be at the all time available in the hospital. He may be at home. What do you think? So you will call the consultant to come from his home. Till he come from home, you will do resuscitation for this patient and take consent and calls the anesthetist, calls the blood bank, and you will prepare her for reopening till the consultant came. After the consultant came, you will leave him and go to the ST2 to help him in the cesarean section. Regarding to the fetal blood sample, you have to justify. If you said you can mention fetal blood sample, no problem. As I said, nothing is extremely low or extremely false or extremely true. If you mention fetal blood sample, no problem. But I think in the strategy they write fetal blood sampling not from 3 cm or below. I think it would be reasonable if you did it after 3 cm or 4 cm, as I remember.
But as I remember from NICE, they said no below than 3 cm.
No what?
This is the cutoff point. No, not below 3 cm.
Not below 3 cm.
Not below 3 cm.
In the NICE?
I think the NICE said like that. I think so. If somebody will confirm this. So
I just read the NICE guideline, but he didn't mention any point of the cervical dilatation or any number of the cervical dilatation. The NICE guideline for intrapartum care, the NICE guideline for intrapartum care 2018. Didn't mention any point or any number of the cervical dilatation, but in the strategy written, it will be done from 4 cm and onward.
Okay, thank you for this nice
welcome.
clarification.
Yes.
Thank you.
You are welcome at any time. Okay.
Dr. Ali, can I ask you a question, please?
Yes, sure.
So about this room 3, we were discussing about 3 centimeter and 4 centimeter. So first of all, the FBS will be very difficult to do at 3 centimeter or even at 4 centimeter. And if she's having a pathological trace. I mean, this is not pathological yet, but if somebody has a pathological trace at 3 centimeter, it doesn't make it is not sensible to do a FBS for her, because she has to progress to 10 centimeter, and a pathological pathological CTG from 3 centimeter to 10 centimeter would be like, it would be risking too much, isn't it?
Yes, sure. Yes, you are right. It will be two length time from 3 cm to 10 cm.
Yeah, so you do it like around when it is 8
centimeter,
9 centimeter, then it makes sense to do a FBS at 8, 9 centimeter, but not at 3 centimeter, unless like you're really sure that the baby is fine.
Yes, especially this is also primary gravida, and she may take time to reach to full dilatation. Yes.
Yeah, correct.
You have to justify, yes. Okay. Okay, thank you all my colleague. We'll end here, we'll stop here, and we'll complete inshallah in our next week, inshallah ta'ala, bismillah. So thank you. If you have any question, if you have any query, please send it in our group, and we'll arrange the time, inshallah.
Thank you so much. Thank you very much, Dr. Ali.
Thank you.
Thank you, Dr. Ali. Thank you, Dr. Ali.
Thank you.
Thank you, Dr. Ali.
Thank you very much. Welcome.
Thank you. Thank you.
Thank you. Welcome. Welcome.